Alrighty, so ready to begin. Thank you everybody for joining us today for our Health Equity Community Forum. It's for those of you that have been our partners and our collaborators in our Health Equity Summit. For the last 10 years, this is something a little bit different. Obviously, with the current pandemic situation, we weren't able to do the full Health Equity Summit this year, but we still wanted to make sure that we are in the community. We talk about some of the health equity issues that are coming out of this pandemic, and we wanted to make sure that there's a voice that can represent some of the needs and barriers that our communities are facing. So before we begin the program, I just wanted to do a brief land acknowledgement. So we're grateful for the opportunity to gather virtually on this land and thank the generation of Indigenous people who have taken care of this land before other nation groups came. We acknowledge that the work of the Council of Agencies Serving South Asians takes place on traditional Indigenous territories of the Huron-Wendat, the Haudenosaunee, and the territory of the Mississaugas of the Credit. This territory is part of the Dish with One Spoon Treaty, an agreement between the Anishinaabe, the Haudenosaunee, and the allied nations to peaceably share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. Today, Takaranto, the traditional Mohawk name of this area called Toronto, meaning a gathering place, and its surrounding areas are still home to Indigenous people, and we're grateful to have the opportunity to meet, work, and play on this territory as settlers. We wish to express gratitude to Mother Earth for the resources we are using and honor all of the First Nation, Métis, and Inuit people who have been living on this land since time immemorial. This recognition of contributions and historic importance of Indigenous peoples must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities. As today's session, we're focusing on health equity. It's particularly important for us to recognize the severity of health inequities in Indigenous communities, and for us to stand in solidarity with the Indigenous communities in calls to all levels of government to develop Indigenous-led health policies and practices that are informed by Indigenous healing practices. We must hold our governments and health institutions accountable and advocate for increasing equitable access to healthcare for Indigenous peoples. We must also continuously educate ourselves about the colonial history of this country and understand how the wrongdoing of the past still impacts the health and well-being of Indigenous communities. I encourage everyone at this session to actively seek information and take action. For those of you that are not familiar with CASSA and myself, my name is Samia Hassan, and I'm the Executive Director of the Council of Agencies Serving South Asians. CASSA is a social justice umbrella agency comprising of over 123 member agencies across the province of Ontario. We're an organization that focuses on providing support to organizations that serve South Asian communities or provide programming that's South Asian in nature or look to empower the South Asian communities. And that's part of our mission, is to fulfill the political, economic, and cultural empowerment of South Asian communities that are living in Ontario and Canada largely. We also do a lot of advocacy, policy, and training capacity building work with our member agencies. We represent the voices of South Asian communities in system level changes. We work with all three levels of government to ensure that the needs of South Asian communities are being addressed and that the barriers that they're facing are being alleviated. So that's our organization. Health equity is actually one of our strategic priorities. We have 5 strategic priorities, and those of you again that are being exposed to our health equity work for the first time, you should know that health equity has been central to CASSA's work over the past decade. We've been working with various different stakeholders trying to ensure that the health of South Asian communities is being addressed in an equitable way. We also work to reduce poverty. We do some work around supporting immigration and settlement. We work around strengthening gender equity. And all of this work is centralized around building an anti-racist and anti-oppressive Ontario. Again, like I said at the beginning, we usually would have done a large-scale health equity summit. And after last year's summit, those of you that attended last year, we were really excited because we were going to expand the summit this year. We received a lot of really great feedback last year. We had the summit in 2 locations, in Ryerson University as well as William Osler Institute, a health system in Brampton. And this year we were going to be partnering with Humber College, and we do have our friend Bharat here from Humber College, as well as William Osler. Unfortunately, that 2-day summit had to be postponed. I think what we're going to do is we would probably have the summit next year, and then use this platform to talk about some of the health related challenges and changes that need to be made that came out from the COVID-19 crisis. So the way that we've designed this session is for us to hear from some experts around some of the work that's been going on in the community, some research related work that's been going on around COVID-19, using an intersectional approach. And then near the end of the session, we also want to hear from our participants. So please don't leave early. If you can stay until 6 o'clock, that would be really greatly appreciated. We'd like to seek your input and feedback around some of the recovery measures and strategies that we need to have in place to ensure that our communities are being looked after to the best possibility. And so we'll have some breakout sessions, just one breakout session. We just have a few questions after our panelists speak. So we have a great set of experts today for you, and I'm really, really excited personally to hear from all of them myself. So we have Baldev, Mutta. I'll introduce each of them individually with their bios, but just so you know who's speaking today, Baldev, Mutta. We have Dr. Nazilla, Khanlou, we have Aamna, Ashraf, Dr. Ananya, Banerjee, and Dr. Sanjay, Ruparelia. And again, we're going to be exploring some support initiatives. We're going to be exploring some of the post-crisis resources that can be helpful to our communities in the situation that we have with the pandemic. So without further ado, I think this is the most that I will talk today. Oftentimes with these sessions, I just want to get right into it and have the least speaking time for myself, but that doesn't end up being that way. So I will hand it off to Baldev Mutta. Just before I hand it off, a small bio of Baldevji. Baldev Mutta has been in the field of social work for the last 45 years. He is the founder and chief executive officer of the Punjabi Community Health Services, PCHS. PCHS is a health service provider in the Central, West, and Mississauga, Halton, Lynn geographic areas. He has worked for the last 28 years developing an integrated holistic model to address substance abuse, mental health, and family violence in the South Asian community. He has received many community awards for his work on equity, community development, diversity management, and organizational change. Baldev Mutta will be addressing marginalized communities and the COVID-19 crisis. Please welcome Baldev Mutta.
Thank you. I'm just waiting for the PowerPoint to come on. Okay, there it is. Thank you. Thank you, Samia, for the wonderful opportunity, and thank you for putting together this wonderful health equity forum. I think it's important for us to meet, talk about some of the challenges we are facing. Often we look at Canada and our struggle from different lenses, but I think it may be really valuable to share our collective experiences, and it will be really good. I just want to present a few kind of remarks based on the presentation. If I can have the next slide, please. So this is a little bit about of our organization. If you need to reach us, you can uh, reach us via our website or via the telephone numbers there. We have three offices, one in Scarborough, one in Mississauga, one in Brampton. And we have been in operation since 1990. Next slide, please. Okay, so let's look at it. The challenges pre-COVID. So one of the things that Canada doesn't do very well is look at the health of immigrants when they come to Canada. They are usually very healthy, but after some times, and usually about 5 years later, between 5 to 7 years, their health is in fact worse than the Canadian-born individuals. So, and that has been highlighted by the York University's research study called the Healthy Immigrant Effect. And it's very fascinating that Canada has known this for a long time. And yet, we have not been able to address some of these issues. We also know that we have a higher rate of diabetes within the South Asian community. We have low cancer screening rates within the South Asian community. We have also known, if we look at the indigenous community, we look at the Black community, we look at some of the other communities, we know that they also go through some specific illnesses. And yet, Canadian federal government and the provincial governments have known it, but no specific effort has been made to address these issues. And that is pre-COVID. So we are at a higher rate for diabetes, at low cancer screening. We know there have been series of studies around heart disease that we are at a higher risk for heart disease. And yet we have been unable to convince the provincial governments and federal governments to allocate money to address the health concerns of our community. So that's pre-COVID. That's the reality that we existed. But there have been a lot of research studies to document that there is a problem, but very few successful projects undertaken to address any of these issues. Next slide, please. So if we look at during a COVID, so what is the challenge? The challenge is within the mental health. There has been well-documented evidence that there is a lot of mental health issues emerging during a COVID. There is isolation, loneliness. And immediately people started shifting to virtual counseling. Now, shifting virtual counseling is not easy. It's not just the technology issue, it's also the issue around addressing some of the challenges of people within the same household hearing about your issues that you may not want them to hear. So how do we address that? That becomes a bigger issue as well. So the crisis kept increasing, and I can only talk about Peel because we are heavily located in Peel between Caledon, Brampton, and Mississauga. So we know how the crisis have skyrocketed to the fact that we had to implement a telephone resource line to just handle the crisis every day, just to calm people down. And then our case managers would come on subsequently to handle short-term kind of counseling sessions with them. The resources, we are underfunded to begin with in the mental health across Canada. I mean, if you look at all the G7 nations, Canada is the lowest term receives the funding. But then when you look at it in terms of certain geographic areas, York and Peel, we are the most underfunded lanes within the whole of Ontario. And then if you look at the way that models of mental health crisis have emerged, we have known that the outcome where police handles crisis situations the outcome is often not very good. I mean, we have a recent case in Peel region where the police's response to the mental health crisis was deadly. Despite all the talk about cultural competency, talking about anti-racism, anti-oppression framework, talking about all the trainings that have gone in, predominantly the models of services are still Eurocentric. I can talk about the challenges that the South Asian community and other marginalized communities go through to handling of privacy, confidentiality concerns, family versus individual, the struggle that goes on, the family wanting to find out information and the professionals not giving them the information, asking the family to stay outside while they want to talk to the youngster. All these issues are not being handled correctly, and as a result, we have serious issues in terms of mental health. So we have mental health, and then we have additional barriers on top of mental health. Next slide, please. So in terms of the response, so what has been the response? The response has been to go virtual. And every organization that is, whether they are in Toronto, they have immediately set up laptops and they are using a variety of virtual networks to get access to clients, whether it's group programs or whether peer support or whether it's families, all of them. But the challenges has been, how do we keep the matter confidential, not in terms of the virtual, not in terms of that the data can be stolen while the data is being transmitted. I'm talking about how do the client feels at home or wherever they are, how many people are hearing within the family. That issue has not been resolved. So we see that at a higher level in terms of abused women, where women are unable to talk because in the family situation. So those are some of the critical kind of issues that are emerging in virtual kind of response. Yet we are going virtually, but then also all kind of different challenges are coming, and still the support isn't there what it's supposed to be. Next slide. So the variety of issues in terms of high risk population, the international students is one that we in Peel deal with. I think this is not new. We have been known this in the whole of Ontario and in Canada. They are one of the highest risk population. Homeless population within the community. I mean, a lot of the dominant culture also says, oh, well, I don't think there is homelessness in the South Asian community or in the any other community. While this is true, within South Asian community, there is homelessness, there is poverty. So our community also goes through the struggle, but somehow it's kind of hidden. Same thing, the high risk population for the indigenous and racialized communities. Seniors are very vulnerable. Newcomers are very vulnerable. LGBTQ population is vulnerable. The question is, how do you reach out to them how do you reach out to a homeless person virtually? That has become a bigger issue. How do you reach out to these communities? For example, seniors, they are at a higher risk. So we had to make some strategic decisions within PCHS, within our organization, that we will provide meals on wheels and we will take care of seniors, doesn't matter how serious the COVID is. And so we used protective equipment for the staff and we kept those services going, while all other services were virtual, but the services to seniors were actually by going into the homes and providing them. So that has been a challenge, and that is the struggle that continues. Next slide, please. We know now, and we have been talking about this for a long time, that the for-profit long-term care homes, that there are greater chances for the seniors to fall through the cracks, and COVID has exposed that. The low staffing client ratio is one barrier, training was another. And if you just read the report of the army that was called in Ontario and in Montreal to look after the long-term care facilities, I mean, that report just brings tears to your eyes. It is so painful to read. And that shows the amount of abuse that the seniors were going through. And I recommend that people read it. I mean, it's just unthinkable that in a country like Canada we would have this kind of treatment to our seniors. And yet the kind of, the actions taken by the provincial government aren't nowhere near in terms of, holding these private corporations responsible. And I think that there has to be a greater effort done to look after our seniors. The second is that PSW as a profession, I think that COVID has exposed that without a PSWs, we will not survive. So now the question becomes, do you pay them the reasonable amount of money to survive? Is that a profession worth keeping? That has been the discussion now centered around long-term care and taking care of seniors. So the COVID has also highlighted how pre-COVID we were treating them and how after COVID we need to treat them. I mean, those are the discussions that we need to have during this health equity kind of discussion. Next slide, please. Funding. This has been a particular kind of a challenge that I have been talking about for last, I would say 20 years, a little bit more than 20 years. Systemic racism in funding. We know for a fact that the existing organizations that are already receiving funding, they already get more funding. But the organizations that are working hard within their own communities are not receiving. So the equity in funding is not there. And that is something that we need to highlight to the funding allocation bodies. Previously, it was Lynn. It took us all this time to make them sensitive to about caring collection of data. And all of a sudden, bang, now Lynn's are being dismantled. A new system is being created. And we still, that systemic part where the funding can be allocated to whoever, that part is still not being dismantled. Data is still not collected, even though they are saying they will collect. Public health departments will be collecting data on race, on COVID, and StatScan is kind of doing certain things to collect the data. But I think that at the ground level, agencies are still not collecting data, so we really don't know what exactly is going on at the ground level. Uh, my beef with this whole training business within the agencies is that somehow trainings will help eliminate systemic racism. It's not going to happen. Dismantling systemic racism is a different baby altogether than training. So trainings alone is not going to do it. Dismantling is a total different kind of a project that the agency has to look at. They have to look at, okay, what is the systemic racism barriers within their agency and how we're going to get rid of it. That's beyond trainings. And I think that a lot of agencies are still, even now during the Black Lives Matter movement, they're still talking about trainings. And now, rather than trainings on cultural competency, now they are talking about trainings on anti-Black racism. And I am of the opinion that these trainings, they are not going to dismantle systemic racism. It's a cop out. And we need to have some discussions on this whole response to equitable allocation and why agencies keep on getting this kind of money over and over again when documentation is not available. When you ask them, well, how many South Asians did you serve? Well, we don't collect data. That's not, I think that's not good enough. Next slide, please. Who is at risk? We know that people with heart disease, and South Asians have higher heart disease, high blood pressure, lung disease, diabetes. South Asians have diabetes, cancer, we have low cancer screening rates. And all of this is that a community is then put it at a higher risk. Now, once we recognize that a community is at a higher risk, the next question becomes, is the government doing something about it? And that's where the problem has been for last 15, 20 years, that they have known that the South Asian community has a higher rate of heart disease, and yet nothing was done. And I think that's where we have to kind of look at, are you just going to acknowledge that we have higher heart disease and that we have higher rate of diabetes and low cancer screening, or are you going to do something about it as well? And I think that's where the discussion should be centered around today, or even after today, around what does equity mean in terms of addressing health concerns of a community. Next, please. I can give you one concrete example. In Mississauga, for example, we distribute meals to seniors in Brampton and Malton and in Caledon. So this is our geographic area. We don't go south in Mississauga. So when we investigated, are any agency delivering South Asian meals to seniors in Mississauga? And all the existing organizations that are delivering Meals on Wheels in Mississauga, none of them have a South Asian component. And so I really became angry that here you have been getting money funded by the LIN. And now, once we raised it, they said, yes, we would like to set up a committee. Can you come on this committee and guide us? How are we going to provide meals to South Asian seniors? So this is the kind of frustration that we get. And I think that we need to kind of look at it. Is it our job to point out the weaknesses, or is it your job to tell us why are you not serving the communities that need to be served? And even if you look at this, another example is that the money allocated by provincial government to Meals on Wheels programs recently during COVID, that only LIN funded agencies were eligible. So we are not LIN funded on Meals on Wheels program. So therefore we were excluded. They knew that we are the only agency serving South Asians, and yet they excluded. So who creates these kind of barriers? I think that we need to have a discussion and to identify what systemic barriers are there to provide services. Unless we can get to systemic barriers, I think that we're going to continue to have these barriers. Next slide, please. We know that with the international students, this is a very big concern. It is on the same level I put it as we put COVID-19. International students have mental health issues. They have drug issues. There is a sex trafficking within our young girls. There is precarious employment. There is housing issues. 8 to 10 students are living in a basement. And then we have recently, both Indus Community Services and PCHS are partnering with Peel Children's Aid to address pregnancies in 9 South Asian young girls who are pregnant. And we are now quickly ramping up our support, because these girls are so young. They are themselves very young, and yet they are pregnant. They're going to become mothers, and yet they have no support here. One young girl gave birth to a baby with 2 other girls by watching YouTube video, because they had no medical. So I think that people are not understanding the difficulty and the precariousness of these students that we are supposed to help. And nobody wants to accept it. You talk to these colleges and universities, no, nothing is going on. We have counseling department and students can come to us and we will serve them. Well, when we tell them that this is what is happening, they say, well, nobody has come forward to us. If they came forward, we will be willing to make a referral. I mean, if this is the attitude of these guys, no wonder that the international students don't go to them. Next slide, please. So this is the data collection that I could find on the StatScan. So they are collecting some data, and it will be released. And I thought that we should have it, and we should, once they have completed the data, hopefully we will get it, and we will then continue to see how different communities were impacted by COVID thing. Next slide, please. So that's all I wanted to present, and then hopefully during the presentations we can later on have some conversation once the presentations are done, and hopefully we can learn from each other at the same time. Thank you.
Thank you so much, Baldevji. I always, no matter when it is, I always really enjoy your presentations and the difficult questions that you ask and that we must address. So thank you for starting that conversation. Next, we have Dr. Nazilla Khanlou. And just before I introduce her, I just wanted to remind everybody that if you have any questions for any of the speakers, you can start to populate the chat. And after all the presentations are over, then we'll address those questions. If you have a question for a specific speaker, you can write the speaker's name and then we'll address that to that particular person. All right, so Dr. Nazilla Khanlou is the Women's Health Research Chair in Mental Health in the Faculty of Health at York University and an Associate Professor in its School of Nursing. She is the academic lead of the Lillian Megan Wright Maternal Child Health Scholars Program. Professor Khanlou's clinical background is in psychiatric nursing. Her overall program of research is situated in the interdisciplinary field of community-based mental health promotion in general and mental health promotion among youth and women in multicultural and immigrant receiving settings in particular. She applies intersectionality-informed frameworks using diverse research methods in community-based research. She is the founder of the International Network on Youth Integration, an international network for knowledge exchange and collaboration on youth. She has published articles, books, and reports on immigrant youth and women and mental health. Dr. Khanlou will be presenting on COVID-19 pandemic guidelines for mental health support for racialized women at risk of gender-based violence. Please welcome Dr. Khanlou.
Thank you very much. So it's a really sincere pleasure for me to be a part of this important event, and I thank CASSA and I thank Ms. Samia Hassan and Ms. Matiba Chowdhury. I've also in the past had some linkage to CASSA through Dr. Farah Islam's connections with CASSA. So thank you very much for having me. And most of what I'm going to present on, I'll also provide links towards the end of my presentation. Next slide, please. So I'm going to do the land acknowledgement for York University. We recognize that many Indigenous nations have long-standing relationships with the territories upon which York University campuses are located that precede the establishment of York University. York University acknowledges its presence on the traditional territory of many Indigenous nations. The area known as Toronto has been cared by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It's now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. This territory is subject of the Dish with Wanspoon Wampum Belt Covenant, an agreement to peacefully share and care for the Great Lakes region. Next slide, please. So we were asked for any disclosures by the organizers, and my affiliation is with York. As far as I know, I have no conflicts of interest, but I recognize that in presenting the information in today's talk, I'm drawing from the literature, and as scientists, our views and perceptions and understanding of the issues are influenced by our own social identities. Next slide, please. The outline I'm going to follow is in line with the idea of identities, who we are at my office, what the issue is that we are looking at today in terms of gender-based violence. And I'll talk to you about some of the initial findings from a recent project that we're funded on looking at this issue with racialized women. And I'm very much looking forward to the discussion questions. It's great to see that some of what I'll be presenting on overlaps with what Mr. Mutta just presented on. Next slide, please. So I hold the chair in women's health research and mental health, but at my office, we take a team approach. And we are particularly interested in community-based research. And what you see on this slide is just a snapshot of our website, and we try and share most of what we do at the office with the public. So our projects, the students, the different initiatives we're involved with, and I'll provide you the website link towards the end. Next slide, please. Here are some of the folks that I have the pleasure of working with. It's not a full list, and I have to say I'm really thrilled to see a couple of my graduate students who joined us as participants at today's event. We take a multidisciplinary approach. So my background's nursing, but we also have psychology, sociology, as well as other disciplines. I have research staff and work with fantastic students from undergraduate to postdoc. Next slide, please. So if I had to describe the type of research we do, it's informed by intersectionality and it's community-based. And you'll see on this slide that we focus on families, youth, and women. So a big line of research for us is immigrant families and impacts of gender and disabilities. We've looked at various outcomes through different studies. We also look at youth cultural identities and currently are doing an arts-based approach in looking at Asian youth identities. That's funded by SHRC. And we are interested in women's mental health, more from a social perspective, I would say, than a clinical one. And so I'll be talking about one of our recent projects today. Next slide, please. When I talk about intersectionality to my students, I say, try and keep three things in mind. That under intersectionality lens or framework, our identities matter. Us as in the researchers, students, as well as who we interface with. But all of this is very contextual. It's not static, it's fluid. And so depending on context, we can have lots of power or we can be powerless. It's not that it's all of this is fixed. So I'll move on to the next slide, please. In terms of gender-based violence, worldwide, it's a key issue. It affects many women, 30 to 60% of women, impacting their health outcomes. 1 in 3 women in the world have experienced physical or sexual violence at some point in their lives. And the COVID pandemic has really worsened the problem, and people are talking about it more and more. Next slide, please. Folks are starting to call this as the shadow pandemic. Recently, I heard it being called as a pandemic within the pandemic. And there's recognition that something needs to be done. The UN Secretary General has asked for the prevention and rectification of violence against women as a crucial part of all governments' national response plans in the context of the pandemic. Next slide, please. So what is gender-based violence? It's violence inflicted on persons because of their gender expression, gender identity, or perceived gender. And it covers a wide range of human rights violations, such as sexual abuse of children, rape, domestic violence, harassment, trafficking of women and girls, and the previous presenter alluded to this. And it has a disproportionate impact on women, girls, and folks who identify as LGBTQ. Next slide, please. The effects are multi and all-encompassing. It has physical effects, traumatic events. It's got psychological traumatic events impacting mental health across a range of outcomes. And there is always this sense of fear experienced by the person exposed to gender-based violence because they are being controlled. It impacts their sexual and reproductive rights, and it impacts their rights to seek care and services. Next slide, please. Within the current context of the pandemic, in Canada, community agencies have reported on the types of violence that women are experiencing, including specific power control tactics that abusers use, such as withholding health cards, access to information, access to the women's children, and even things like soaps and sanitizers, which are key for our health. So it's very specific type of tactics are emerging. Next slide, please. As a result of what we were hearing and what we were being told, we applied recently to CIHR for a focus they have on mental health support during the current COVID pandemic. And there is my amazing research team. It's interdisciplinary, it's intersectoral, and I specifically want to mention the two community knowledge users collaborators we have on this. Dr. Andrew Savi is an international trained medical graduate, and he's the manager of the Newcomers, Families and Clinical Programs Services at South Riverdale Community Health Center. And Dr. Sajid Zahrai is the Senior Manager of Professional Development Training at CASSA, which is the Ontario Council of Agencies Serving Immigrants. I also want to acknowledge my project coordinator, Dr. Luz Maria Vasquez, who is phenomenal and has helped me put together today's presentation as well as the PowerPoint. So thank you, Luz. Next slide, please. Our study objectives in general are to try and further understand the social determinants of mental health among racialized women and girls who are exposed to gender-based violence during COVID-19, but also to identify what are some of the promising practices for detection, referral, and provision of service. Next slide, please. So we're applying a rapid literature review methodology drawing from Cochrane's approach. And I won't go into the details of this, but we are interested both in peer-reviewed literature as well as gray literature. And at the end, when I provide our email, if you know of any literature, whether it's unpublished, whether it's gray literature, or whether it's peer-reviewed, please let us know that address this area. So what I'm talking today about is drawing from 7 peer-reviewed articles and more gray literature, which is growing rapidly during the COVID crises. Next slide, please. What's emerging from our review of literature is that this is a complex, multifactorial. Some of it is embedded in gender-based violence risks in general, and others is specific to the pandemic. Here is a diagram through which we try to bring it all together, and I'll be talking about a couple of these areas momentarily. But issues around social isolation, issues around economic insecurity and poverty, reduced or closure of essential services are issues. There's increased unpaid caregiving, especially for women when folks are working from home. Racism, discrimination, and xenophobia that's specifically emerging out of COVID-19 related racism is another area. And there are COVID-specific sources of violence. And there's increasing violence against healthcare workers, most of whom in Canada in the labor force are women. Next slide, please. So I'll be talking about, just briefly, about some of what's emerging. We know that racialized communities bear a disproportionate burden of stress, illness, and health inequities. And from Europe and United States, we know that there's alarming rates of infections and deaths among Black, Latino, and Asian populations. In Canada, we don't have disaggregated data that much to see what's happening. And unsurprisingly, we are seeing that the social determinants of health has a big impact on who's at risk. Next slide, please. So looking at racism, discrimination, and stigma, there's been increased risk of racial and sexual harassment, both online and offline, of targeted sexualized attacks against women of East Asian ancestry, from the blaming of Chinese Canadians, especially restaurant owners, especially earlier on in the pandemic, as guilty of transmitting the virus, to refusing to hire East Asian-looking Uber drivers. These are some of the issues that are being documented. Next slide, please. In terms of mental health, In a recent survey, service providers reported that the victims of violence against women are increasing reports of increased anxiety because of issues such as safety, finances, childcare, and anxiety related to the pandemic in particular. Next slide, please. So this is how we try and apply an intersectionality lens in looking at the literature. On one side of the diagram, you see the social determinants of health, and we try and understand what are the mediating pathways through the inequalities that particularly disadvantage racialized women in the current context, disadvantage them socially and from a health perspective. Next slide, please. So there are in the literature, both gray as well as peer-reviewed, a lot of suggestions, recommendations that are coming up. And what we're doing is trying to organize these recommendations, taking an upstream approach through categorizing them at the macro, meso, and micro level. And our first report has the details of all these points that I have on this slide. It's just giving you a sense of how we are looking at it as a systemic social issue rather than it's just the woman's problem. So really looking at upstream measures. Next slide, please. This is an example of a recommendation that's at the meso level in terms of strengthening services for women and girls. For example, World Health Organization guidelines says that we need to ensure services for women and girls and consider them essential in the current context. Other suggestions are services being well-funded and inclusive, expanding access points to mental health services, and as well applying a holistic trauma-informed approach to service provision. Next slide, please. So I'm getting towards the end. The first URL link is what's posted on all the projects funded currently under this mental health and substance abuse initiative. And the second URL, which is on the same website, takes you to all of our emerging reports, documents that are coming out. And we'll be updating these on a monthly basis until October as per the funding opportunity. Next slide, please. So there is our website, and we have an email. So if you know of any literature, as I said, whether through your organizations, whether through grade literature, through peer-reviewed literature, please send us an email. Our office has a Twitter account, and I have a Twitter account, which is on that slide. As we move towards the discussion phase of today, next slide, please. Some of the items that you may want to consider. Next slide, please. Is how do you think the COVID pandemic has affected the mental health of populations or individuals, gender-based violence, provision of support for racialized individuals, and more importantly, what are some of the promising practices and policies do you know of that provide support for racialized women at risk of gender-based violence? And on the final slide, I provided, next slide please, a list of references, and the font is tiny, but I tried to keep it to one slide. And thank you very much.
Thank you so much, Dr. Khanlou, for that presentation. So again, if you have any questions for Dr. Khanlou, you can put them in the chat box and we will address them after all the presentations. So we are running a little bit behind our schedule, so I'd request our speakers if they can keep that in mind as they're presenting and stick to their 15-minute limit for the presentation so we can have a little bit of time for discussion. So our next speaker is Aamna Ashraf. Aamna Ashraf is the manager of health equity at the Center for Addiction and Mental Health. She is a well-known figure in the field of health equity and is an experienced professional in the areas of program and policy implementation, stakeholder development, and partnerships. Aamna holds a master's degree in education, counseling psychology, and has worked in the not-for-profit sector for over 25 years. As an advocate for health equity, Aamna leads the award-winning Immigrant and Refugee Mental Health Project and serves as one of Ontario's Health Equity Impact Assessment champions. She previously worked as a senior program advisor in refugee resettlement with the Ministry of Citizenship and Immigration. Before this, she was the director of Peel Newcomer Strategy Group Local Immigration Partnership for Peel. Aamna also worked at United Way Peel and has led service development for diverse populations at Canadian Mental Health Association, Toronto. Aamna will provide an overview of the response of the Immigrant and Refugee Mental Health Project to COVID-19. Please welcome Aamna Ashraf.
Hi, everyone. I guess I can just see my slides and I can see Samia. Yeah, okay. So I wanted to go through these slides more so why we were focused on the project was within my role at Health Equity at CAMH. There are many areas that we've been focusing on in COVID-19, but we thought that paying particular attention to this project would be really helpful because I do think it will actually reinforce some of the things we heard from Baldev and Nazilla, specifically around what service providers are saying and some of the challenges in COVID-19. So I'm going to go to the next slide, which is our agenda. Just a second. Okay, so I'll give you a little bit of background on what we do in health equity at CAMH, the project itself, and then our response to COVID-19. So you can skip the next slide. It's just my introduction. You can skip that. Yeah, and then the land acknowledgement. I know that you did a land acknowledgement, Samia, but we also wanted to do one in terms of where CAMH is situated. So I'm just going to do a sentence recognizing the time, but the site of CAMH appears in colonial records as the council grounds of the Mississaugas of the Credit First Nation. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich the city. CAMH is committed to reconciliation, and we will honor the land through programs and places that reflect and respect its heritage. So we do have that in the slides for everyone. We can go to the next slide. I don't have anything to disclose. I think the bio speaks for itself in terms of the different lenses I may bring into this. So if we go into the next slide. So when we talk about health equity in the Office of Health Equity at CAMH, if you go to the next one, we look at it as it's the principle underlying a commitment to reduce ultimately eliminate disparities in health and its determinants. Pursuing health equity ensures that all people reach their full health potential and receive high quality care that is fair and appropriate to them and their needs, no matter where they live, what they have, or who they are. The next slide is one of the main slides that we often show. And when we try to talk about equity and health equity specifically, we talk about the determinants of health. And this is a really great slide because it talks about what makes Canadians sick. So 50% is your life, 25% is your healthcare, 15% is your biology, and 10% is your environment. So how these affect one another, obviously, are pretty critical. But again, it does speak to privilege, and it does speak to social location, and it does speak to intersections. So if you look at the next slide, health inequities and social determinants of health. For many of you, you might already know this. Social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And that's according to the World Health Organization. Next slide. So I just wanted to give an overview of the Office of Health Equity, which is within CAMH. So while we have this project, that's the Immigrant and Refugee Mental Health Project, we also do research and evaluation. So one of our research projects is actually with Baldev, and it's the Culturally Adapted CBT for South Asians. We are in partnership with Punjabi Community Health Services and 2 other agencies across, one in Ottawa and one in BC. We also do other research and eval, which is primarily on interpreter studies and other pieces. We do education and training. So we do a health equity certificate program within CAMH, which is a range and a roster of accredited courses. We do clinical service improvement. We work with clinicians around health equity outcomes. So that's looking at socio-demographic data collection and the impact of disaggregated data, etc. The other thing that falls in my portfolio is interpretation services. And I think this is really critical in terms of mental health. We have mental health interpretation, of which we look at 45 interpreters that support CAMH. And so that's we get about 4,000 requests per year around interpretation. And then we have diversity at CAMH, of where this is a joint position between Human Resources and the Office of Health Equity to look at all the ways in which we are recruiting, promoting, looking at human rights issues, grievances, etc. So next slide, the Office of Health Equity in COVID. So where our energy has been in the last little while has been looking at our interpreters and how they can virtually support the clinicians, as well as the fact that, during COVID, we had to go virtual. Then we also have been talking about what virtual mental health looks like, what are the key considerations that need to be taken into place. And then the research piece. So another part of our research is looking at pathways and virtual pathways for refugee populations. And that's something that we're also looking at. So if you go to, not the next slide, if you go to next one, yeah. So overall, the reason I'm talking about the project is while we are not frontline in this office, we really do get a lot of our information from service providers across Canada, much of which actually Baldev has actually already raised, as is Nazilla, and it's very consistent with what we're hearing. So the Immigrant and Refugee Mental Health Project is funded by IRCC, so the federal government, and it has 5 components. So we have online training, tools and resources for settlement, social, and health service professionals. You'll have the opportunity in this course, if you are a social worker or a settlement worker, you're allowed to take this course free of charge. It's run 4 times a year, and you can connect and exchange ideas. We have a community of practice. We link you to psychiatrists as well as settlement workers to sort of troubleshoot. And really and truly, we acknowledge at CAMH that we're the convener to this information. We highlight best practices across Canada that can be shared with settlement. So there are 5 components to the course. It's evidence-based, there's evaluation, networks, it's interactive, there's expert videos, it's self-directed, and it takes roughly about 35 hours to complete. So our course enrollment is fairly high. We do have, about 2,000 people a year that we do, that we have enrolled in the course. The fall offering is in September this year. I encourage, and we will send out the links for those that are interested in taking the course. And so in terms of our project response, if you go to the next slide, what we heard was from a lot of our, for the people taking the course, was that how do we support immigrant and refugee populations, number one, but then how do we support service providers who are trying to make the transition to virtual during this time? And what are the key considerations that we need to do? So this wasn't an area that we had sort of planned on, of course, like many others. We hadn't planned on being able to provide this response immediately, but what we did do is we did an Ask the Expert session. And we had Bonnie Wong, the executive director from Hong Fook. We had Vince Pepicciolo from CASSA, and we had one of our psychiatrists from the refugee clinic do an Ask the Expert session. So if you go to the next slide. So the pandemic, it brought mental health implications for everyone, including immigrants and refugees. We did convene this in English and French. So we had Rada Hassan from Quebec do the French Ask the Expert. And these were 1-hour live events. We will send you the links. If you're interested in looking and reading about what was brought forward, we're happy to share that as well. So some of the sample questions, if you look at the next slide, was there seems to be an increase in domestic violence in the home. How do we make cultural safety plans remotely from within the home? So similar to what Nazilla had spoken about, as well as Baldev. And how do we manage triggers from COVID-19 for refugees and immigrants that can trigger them to previous traumatic experiences? Food shortages, not being able to go into the public, etc. Another question was, how do I connect to people in the need of counseling during the COVID-19? What mental health resources and supports are available in other languages? How to best support families who have children in the home, particularly as schooling is being done from home. So you have to really understand that the people asking these questions are from all over Canada, and some are rural communities, some are communities with less resources than Toronto, some are communities that aren't connected to other settlement agencies. So it was a real opportunity to say, okay, here's some of the resources we have. So for instance, Bonnie from Hong Fook was very generous in saying, here's some privacy things that we have been able to create. We're happy to share these resources. Vince was able to say, well, we have, different things that we do for self-care for service providers, and here's what we do. But he was also able to share about, what are the ways in which we have safety plans and what are some of the things that we can do on screen that ensure that there's a level of privacy or they're able to communicate with us some of the ways in which they may need help. So if you go to the next slide. So themes for questions posed. Again, if you look through this, supporting immigrants and refugees remotely. So the protocols, as I mentioned, managing triggers from past trauma, connecting newcomers to mental health services. And in French, what we heard was supporting newcomer children and adolescents in this context, effective ways to ensure the well-being of clients with respect to sexual and gender-based violence, and supporting older immigrant and refugee adults during this period. So our response, if you look at the next page, was we created a special page of COVID-19 resources, and we have the links here. So, and we also have monthly newsletters focusing on newcomers' mental health and COVID-19. So what we try and do is collate a lot of this from the experts in the field. We don't own that information in terms of expertise, but what we do is be able to say, well, here's different ways other people are doing it. Don't exhaust yourself in creating the resource, but really leverage the kind of expertise that's around. And, one of the things that I've worked with the settlement sector for a really long time, and many people will share their resources with one another, despite the fact that there's this, competition for funding, or the fact that many people are looking at, how they can have intellectual, property, or I don't see that as much. I see many people coming to the table with, here's what we're doing, what are you doing, how can we help? And so we've been able to really leverage that sort of expertise and create a page that we can send out to people, and we're constantly updating that. So if you look at the next slide, in terms of emerging issues. So issues observed in various provinces. So these were things that were raised by some of the folk on the call, and it was how to help people re-enter society. So with a sense of trust and safety, particularly those experiencing social anxiety. Issues around gaming and gambling among children and youth due to extensive time online. Like, what do we do about that? So these were some of the themes that were emerging. Parenting and dealing with family issues during the pandemic. Exposure to what family members are experiencing overseas. So again, a lot of information that's been given through the media around what's happening in other countries, and then not being able to actually travel or reach out was also a key concern. So in terms of my last slide around what's next and what we're doing next, we are looking at some research in these areas with some of our partners. We have been asked to support service providers further, so it is about creating some more resources, and we will be looking at some videos, some mental health tips, and those kinds of things. We have the Health Equity Impact Assessment. It's the HIA tool, and we're looking at that in terms of who's excluded and what policies and programs are able to adapt and what they need to do. We're looking at virtual mental health and sort of some key considerations that we need to consider when, as Baldev mentioned, around privacy and confidentiality, and what home structures, and really and truly what data looks like for people, and how much they're comfortable with virtual mental health before we suggest that as an option. And then we have the culturally adapted CBT research that we're doing that we hope that we'll be able to inform some of this as we move forward. So the last slide is really on staying connected. You can email me anytime with any questions. I'm happy to answer them. And we put the registration up here if you'd like to take the course. And if you'd like to access the online newsletter or any of the COVID resources, you're welcome to do so. They're all free of charge.
Great, thank you so much, Aamna. So if there's any questions for Aamna, please post them in the comment box and we'll get to them after the remaining two presentations. Our next speaker is Dr. Ananya Banerjee. Dr. Ananya Banerjee is an assistant professor in the Division of Social and Behavioral Health Science and Epidemiology at the Dalla Lana School of Public Health, University of Toronto. Her public health research on diabetes prevention for South Asian communities exemplifies a commitment to providing a strong foundation in mixed methods guided by principles of socio-ecological framework, anti-oppression, intersectionality, and community partnerships and cultural safety. She launched and offers the first course on race, ethnicity, and culture and health for graduate students at the University of Toronto. Dr. Banerjee will be presenting many factors that overlap with our South Asian identity, with knowing how they work together as we fight for equity before, during, and after this pandemic. Please welcome Dr. Banerjee.
Thank you so much, Samia. So I'm going to take a bit of a different approach from my fellow guests. I actually don't have a slides. I'm going to share more of a reflective piece and perhaps share the struggles that I have been having as a scientist doing research with South Asian communities. And this is a piece that I hope to publish soon. So I'd love to hear your feedback. Essentially, this essay is called Reflecting on What It Means to be South Asian During the COVID-19 Era. Before I start, I want to provide my sincere gratitude to CASSA for inviting me today on this panel with everyone. I've learned quite a bit in the last hours. So I want to acknowledge this land I speak on as a settler, which has been home to current and Indigenous communities. I acknowledge as a child of immigrant parents, I have been the beneficiary of Canada's policies that have discriminated against Indigenous communities. As an educator at the U of T, I am committed to truth and reconciliation and will support my Indigenous students and colleagues and their communities to affirm their inherent rights. I also wish to pay respect to my ancestors, and I hope my words will please them and everyone who is sharing this space with me today. I have no relationships tied to this presentation to disclose. I want to thank my colleague, Nuza Hafleen, for reviewing parts of my presentation. The question I come to you today is to reflect on what does it mean to be South Asian during the COVID-19 era? What has it meant for you to be South Asian? This is a question I'm asking myself too often over the years as I work alongside with very diverse South Asian communities to break the cycle of diabetes and now being more susceptible to coronavirus, but understanding we are more protected compared to our Indigenous and Black communities. The South Asian identity is important for all of us and brings us together in solidarity. And we have organizations such as CASSA for being that mechanism. However, it's time we must question who we are and where we sit on the spectrum of power and privilege among the South Asian diaspora. My parents are first-generation immigrants from Kolkata, India, the colonial capital, who came to Canada in the 1970s. I remember their stories, as many of you do, of how our parents came with very little and their struggles during the resettlement process. I asked my mother recently, were her struggles the same as South Asian immigrants who arrived to Canada today? Her response was no. She said our struggles were much less. My parents came as a result of a new immigration regulation in 1967 based on a points system and met the criteria of English language fluency, university education, and job skills, coupled with having privileges as a result of their South Asian identity that included being a lighter shade of brown, Hindu, Brahmin, and Indian. Her risk for COVID-19, despite her age and being a cancer survivor, is low as a result of her privileged migration history and identities, and immensely benefiting from the structure of Canada. There are many factors that overlap with our South Asian identity. It's about recognizing the web of overlapping discriminatory factors such as caste, gender, sexuality, economic class, race, and religion faced by people of the South Asian communities. Intersectionality is knowing how they work together as we fight for health equity before, during, and after this pandemic. It is understanding a South Asian physician living in Rosedale versus a South Asian Amazon worker living in Rexdale will have a very different risk factor profile for COVID-19. The fight for equity right now is not and should not be about connecting all South Asians by one string. As South Asians living in Canada, we are not marginalized equally, and we are rooted in and perpetuate the hierarchical structures of colonial governance. We know a number of underlying conditions, including lung disease, heart conditions, and diabetes, that make individuals more vulnerable to and experience complications from COVID-19. It's clear, South Asian immigrants are more likely to have type 2 diabetes than the general population in Canada. And what's frustrating is this research has been continuing over the last decade, and we have not seen any reduction in the rates of the South Asian community suffering from diabetes. Therefore, from a biomedical perspective, South Asians are at high risk to develop COVID-19. However, combining all South Asians into a single South Asian category masks our heterogeneity based on our intersectional identities. Therefore, as public health units begin to collect race-based data, we need to advocate for the disaggregation of data as an important source of high-quality monitoring of South Asian health and health disparities in COVID-19, and among other health and mental health conditions. Many communities of the South Asian diaspora will be left behind if their only option is to check the South Asian box on medical record forms. Drawing on my epidemiological research, looking at examining the differences in the prevalence of diabetes across the Canadian South Asian diaspora, we found among 200,000 South Asian immigrants that the rates of diabetes differed depending on which region of South Asia they immigrated from. After controlling for age, sex, and income, immigrants from Sri Lanka have the highest rate at 24.3%, Pakistan followed by 22.2%, Fiji 21.5%, Bangladesh 20.7%, the Caribbean 20.4%, India a dramatic drop at 16.0%. South Asians who came from East Africa, South Africa, and the Middle East, on average, their rates of diabetes is 10%. Higher prevalence was evident among men compared with women in all the subgroups. We also found the lowest income South Asians in Ontario are from Bangladesh. South Asians from Sri Lanka, the Caribbean, which is a community that is very left behind among the South Asian diaspora, and Fiji had the lowest educational opportunities. Migrants from Sri Lanka had the highest proportion of refugee status upon arrival in Canada. So when we look at these compelling figures and statistics, how can we say, as a South Asian community, we have a collective higher risk for COVID-19? Based on this data, we cannot assume the risk for COVID-19 will have a one-size-fits-all approach. We need to understand certain South Asian communities undergo significant higher stress due to a new environment, particularly to this day, that is tied to social, economic, and language disparities. And the job challenges faced by newcomers compared to, for example, my parents' generation during this pandemic is astronomically different, and it's still based on their intersectional identities. We have to understand these factors will play a significant part in having a higher risk for COVID-19. Let me bring you some context. Early research in the first patients critically ill with COVID-19 in the United Kingdom have shown that Black and South Asian people are more likely to be badly affected by coronavirus than white people. But they dug deeper. They found that among South Asians, that Bangladeshi and Pakistani people residing in England and Wales have the highest deaths from COVID. New York City's Bangladeshi community struggles to cope with COVID-19, primarily living in the Queens, the Bronx, and Brooklyn. These areas have some of the highest numbers of confirmed coronavirus cases, according to government data. If you ask someone from the Bangladeshi community in New York, they know someone or of someone who has died from COVID-19. What is important to understand, it is a working class South Asian communities that are affected and who can't afford to quarantine. They are hit particularly hard due to high levels of poverty, food insecurity, close living quarters, many working in the informal labor market, coupled with having high rates of diabetes. They are being targeted based on where the virus has been stronger. Due to the Bangladeshi community in New York being primarily Muslim, this has led to false claims that Muslims are testing positive for COVID-19 at higher rates than others, leading to a rise in Islamophobia. There have been calls to boycott on social media Muslim businesses, including vendors, small business owners, and essential workers like domestic workers, cooks, as well as health and relief workers. Further, social distancing is held to justify illegal casteist practices of untouchability and to legitimize the social boycotting of Muslims and Dalits. Popular Islamophobic COVID-19 content, it has been amplified by major news media outlets, which compounds to the damage. Dalits, more than any other caste group in the US, report feeling discriminated at a place of business or service because of their caste. This is most commonly stated to be in corporate environments, restaurants, and even retail stores staffed or managed by privileged South Asians. So I think many of you are thinking, well, that's the US, right? We know racial segregation, particularly because of the BLM movement. It makes sense that it's happening to South Asians in the US, but we can't ignore the fact that yes, it is happening here in Toronto. We begin to see our South Asian communities being targeted as well. This is where public health data can be more harmful than good in the context of health equity. The media has brought quite a bit of attention to the Thorncliffe Park area, and CBC headlines this geographic area as a hotspot for COVID-19. What happens when people read this? It creates a lot of community stigma and misinformation. Small South Asian businesses in the Thorncliffe area are being impacted as neighboring communities, which include rich areas such as Leaside, fear of catching the virus. Messages are being circulated on social media by people after reading the CBC article. Please avoid non-essential travel and maintain physical and social distancing. If you would like to help the Thorncliffe community, please help by not going there. These words can be very well from privileged members of the South Asian communities who don't have a grasp on anti-oppression, social justice, and equity. All of us here on this Health Equity Forum, we are a very specialized niche group. Thorncliffe is a home to a South Asian majority and a high proportion of South Asian communities who are Muslim and who are likely facing a rise in Islamophobia as in the US. Though we don't have the data, it is likely that low-income tenants, particularly South Asian newcomers, are highly vulnerable, that parallels to the Bangladeshi communities in New York. They are also more vulnerable to evictions during this pandemic, a conversation I have yet to hear among ourselves and outside the South Asian communities. When families are unable to pay the rent, they are often turned to their extended families for shelter, which leads to overcrowding of units. Recent immigrants often face huge challenges contesting evictions, mainly because of unawareness and knowledge of the law and language barriers. The Thorncliffe community also has many essential workers and refugees that fear migration consequences. Therefore, South Asian communities with a lack of resources and services are the ones who are being disproportionately affected by COVID-19. The diversity among South Asian Canadians is beautiful, and I think it is a strong asset of our racialized community in Canada. However, it's important that we also integrate the ways we are situated with our South Asian communities and not just do a comparison to white communities. Prevention efforts for COVID-19 has to take into account the social political history of our South Asian identities. It is time we share our stories without judgment and advocate for ourselves. But we also can't pretend that we all share the same experiences or that we can always center ourselves in conversations about injustices against South Asian people. For the more structurally privileged amongst us, especially, really need to stop using our South Asian identity as a shield to deflect from recognizing our privileges. Being South Asian together means to collaboratively think of ideas to counter oppressive systems impacting South Asian communities based on their legacies, histories, and social identities. Thank you.
Thank you so much, Dr. Banerjee. So we have one last speaker, Dr. Sanjay Ruparelia. Dr. Sanjay Ruparelia is an associate professor in the Department of Politics and Public Administration at Ryerson University. He holds a Juralski Democracy Chair. In addition to a PhD in politics from the University of Cambridge, Dr. Ruparelia holds a Bachelor of Arts, Honors Political Science from McGill University, and a Master's of Philosophy, Sociology, and Politics of Development from the University of Cambridge. Prior to joining the Department of Politics and Public Administration at Ryerson University, Dr. Ruparelia was Associate Professor of Politics at the New School for Social Research. Prior to the New School, he was Assistant Director of the South Asia Institute, a lecturer at Columbia University, and served as a consultant to the United Nations. Dr. Ruparelia's research addresses the politics of democracy, equality, and development in the post-colonial world, as well as the role of parties, movements, and institutions in politics. Dr. Ruparelia will briefly address how the pandemic has exposed and deepened socioeconomic and health inequalities in societies throughout the world and in Canada too, and that planning for post-crisis requires far greater preparedness by governments in terms of data collection, testing, tracing, and new social contract. Please welcome Dr. Sanjay Ruparelia.
Thank you. So thanks to Madiba Chaudhary and Sanya Hassan for inviting me to join this discussion today. And like Dr. Banerjee, I don't have a PowerPoint presentation. I'm just going to speak very briefly, and particularly because I'm the last speaker and it's been some time since we began. I'm sure the audience and participants in the webinar would like to participate in some discussion. So I'll be fairly brief. Before I begin, as a member of the Faculty of Arts at Ryerson University, I would like to acknowledge that Ryerson is on the territory of the Anishinaabe, Haudenosaunee, and the Huron-Wendat. It's covered by the Dish with One Spoon Treaty, Treaty Number 13, and the Williams Treaties. The Faculty of Arts at Ryerson is committed to honoring our obligations to these nations and treaties and to justice for Indigenous peoples generally, by hiring more Indigenous faculty, by bringing an Indigenous lens to the curriculum at the university, and with the hope of attracting more Indigenous students through scholarships and other means to recruit them. And we're also committed to supporting the work of the Yellowhead Institute, an Indigenous-led research center based at the Faculty of Arts that provides critical support and resources to Indigenous communities in their path towards self-determination. I'm not aware of any conflicts of interest in participating today in this discussion or in what I'm about to present. Unlike most of the speakers who've already spoken, I'm not primarily an expert in health or public health. I'm a student of democracy and development, and most of my work actually has been in India for the last 25 years, and more recently China and the global South generally. But I think a lot of what has already been said resonates with what I have studied about the pandemic in the last 3-4 months as it's taken its toll. And one of the things that I'm studying is trying to understand comparative responses to the COVID pandemic around the world. And principally, why is it the case that on the one hand, particular communities, individuals, groups are disproportionately affected. So one of the major issues we've been discussing today. But then also, why is it that certain countries seem to be responding better than other countries? And so I'm going to try to give a broad global picture and try to put Canada and situate it in that. So three very sort of general sets of remarks. First, of course, is the impact of the pandemic. Disproportionately, as we've been hearing all through this webinar, has affected racialized identities and minority communities across the world. And what's very striking about this is that it's across the world, across the North-South divide. So of course, we in Canada, looking at what's happening in the United States, are very aware of how it has disproportionately affected Black communities, immigrant communities, Indigenous communities of various kinds, also those, of course, who are working class. But we see that in the United Kingdom as well. I think it was Dr. Banerjee who spoke about some of the data there on the fact that South Asian communities, and particularly Pakistanis and Bangladeshis within the United Kingdom, have been disproportionately affected. We even see it in Singapore, a state that was heralded as being one that handled the pandemic very well in the early stages, and it generally has generally been sort of feted by not those who are advocates of democracy, but of governance, as being a state that's very well equipped to provide public service as well. And we see that actually there's been a massive surge in cases in Singapore, primarily amongst lots of workers who are from South Asia and the Gulf, who are working there and in very cramped quarters, very low wages, and they've not been taken care of or treated in nearly the same way. And it's been incredibly vivid exposure of the deficits in Singapore itself in terms of its governance structures and the stratification in society. So you see it there. And of course, we see it in India, in South Africa and Brazil. And since this is a forum on South Asia, let me just speak briefly about India. As we know, the government in New Delhi took quite some time to respond. And when they did, they responded in a very draconian fashion, with barely any notice given to the citizens of the country, one of the most severe lockdowns in the world, with less than 6 hours notice. And the immediate effect was on migrant communities, numbering anywhere from 50 to 100 million people who are living in the cities of India, who were suddenly forced to survive, literally. They lost their work, they lost their place of residence. They were hounded and stigmatized, of course, by many people who were fearing the pandemic. And so we've seen many of those images of literally millions of people walking and trying to make a journey back to their rural communities where they come from. These are seasonal migrants and very much left at the mercy of charity and volunteer groups that were trying to protect them. And that continued after the lockdown extended for another 6 weeks. And now we see, of course, as India is opening up, like in many other countries, that these workers are also principally exposed. So if you think about why is it the case that particular communities are disproportionately affected, you can think of three broad factors. One is, as we've already been discussing, the incidence of morbidity, pre-existing conditions in many of these communities, primarily because of the socioeconomic status and opportunities, and which leaves them very vulnerable to the pandemic. The second, as also we've been discussing, are the living standards and household characteristics. In many of these populations, their access to public amenities and services, which leaves them vulnerable, but also makes social distancing harder. And the third is that many of them are frontline workers. And this can be in quite different occupations. It could be in the healthcare services amongst doctors and nurses, but of course it can be also in lots of essential but lower wage paying jobs that have precarious contracts in the formal or informal sector of the economy, and that leaves them vulnerable as well. So this is a broad picture. What's striking about it is that it's, I suppose we can look at some countries that have protected more vulnerable populations better, but it's a pretty broad picture that applies across the world. So how has Canada done in this? This is the sort of second major point, and I'll just sort of state it briefly, which is in comparative terms, Canada seems to have managed the pandemic relatively well. And you might attribute that to two, again, broad factors. One is relatively sound political communication from the top. That's not always the case, as we know, in Ontario. Mixed messaging and confusion in the last couple of months about how much social distancing was required and under what conditions and so on. But again, if you're comparing how the government in Canada has handled this at the national and provincial level to the United States, the United Kingdom, Brazil, I mean, these are the most egregious cases. Canada's probably somewhere in the middle to the upper end of the pack in terms of countries that have handled it relatively well, not as well as Taiwan and South Korea, Vietnam, for instance, but not nearly as badly as Italy and Spain and France. So it's sort of relatively well in general terms. And like I said, I think you can attribute that to political leadership and style of communication at the top, which has been relatively sound, and also largely citizen social distancing when they can in these last 3 months. But it is also exposed, as everyone who's spoken before me has done in granular, vivid detail, the socioeconomic inequalities in our society. And also, and this is what I'll probably emphasize a little bit in my last couple of minutes of speaking, the inadequacies Canada has shown in state capacity. And I think there's sort of 3 areas we can focus on. One is the lack of preparedness for the pandemic. The second is its testing regime. And the third is its contact tracing. And what's very striking here is in comparative terms, and many people have been seeing this in the media that's coverage, the Globe and Mail has done a really excellent series on preparedness or lack of preparedness. What's so striking in the Canadian context is a number of commissions and inquiries that have happened over the last 15 years, more or less predicting that this type of pandemic would happen. And none of the recommendations of these commissions were really implemented or followed through. So we learned early days, not only that the government didn't respond quite as quickly as some other countries that responded better, but stocks of PPR were inadequate. Coordination between the provinces and the center was not as quick as you would hope. There's sort of a lack of preparedness, not because we didn't have knowledge within existing health communities, whether experts or doctors and practitioners, professors who study this, but because there was just almost a sense of complacency, I think. And I think that's something that we have to sort of think about moving forward. A second area is testing. Testing in Canada has been very inadequate in terms of the level of testing, the accessibility of testing compared to the best countries in the world. The number of days it takes to get a test result, as a lot of media have been reporting, sometimes as far beyond a single day. Even within 6 weeks ago, I remember reading coverage in the Globe and Mail of some people undertaking tests, doctors and our universities taking 3-4 days to find out that they had a positive test result or not. And then, of course, allied to that is the question of contact tracing. There's a lot of controversies and important issues to deal with this, which has to do with privacy and security of data. But again, what's very striking is how effective has the contact tracing been, given that it's a pandemic, given that it has an exponential growth rate, the speed at which public authorities are able to trace the incidence of this disease in order to contain it is really vitally important. If you look at the countries that have done this well, and they've used different strategies, so there isn't a uniform set. If you compare Vietnam, South Korea, and Germany, for instance, they use very different strategies to control the pandemic through contact tracing, but they're all extremely effective. And what's very striking is the level of resources that they've mobilized and the speed with which they're able to trace anyone who has a positive test. So I think I'll just end by saying, going forward, we need to think very seriously about the recommendations that a lot of public inquiries in the past, and certainly there'll be another one in this pandemic, have recommended to see that they're implemented. Second, I think we need to collect much better data on ethnicity and race. Dr. Banerjee talked about, very importantly, to disaggregate this data by class and nationality and religion. And I think that's crucial because we're not a homogenous community by any means. And in fact, there are disparities within us. But I'm also very struck, and this could be seen as quite ironic, that Canada, which celebrates its multiculturalism as official government policy, and of course its liberal democratic credentials, is compared, for instance, even to the United States and the United Kingdom, one that does not collect data systematically on race and ethnicity when it comes to public health outcomes, which seems to be very important. And not only that, but public data is incredibly hard. I've just returned to Canada after 25 years away. Public data is very hard to actually access by StatsCan and other government authorities, which again, you would think is quite ironic or paradoxical, given that it's a liberal democratic regime, which sort of celebrates that. So freedom of information actually is it's quite limited in Canada compared to many other jurisdictions. And lastly, as I mentioned, test and trace. I think for a pandemic like this, I'm looking at questions of state capacity in my research. And these seem to be two important levers of state capacity, have to really be ramped up quite dramatically in the weeks and months going ahead. working with expert practitioners, as well as civic organizations, in order to mobilize social awareness about the importance of that. So let me just sort of end there, because I know it's already been a long webinar, and I look forward to any comments or questions that might come up. Thanks.
Thank you so much, Dr. Ruparelia. So we do have some time for some questions. So we're actually going to restructure the breakout session. Sorry about the sun in my face. The breakout sessions, we are creating a quick survey that we will send out to everyone right after the session. And that will include the 2 questions that we had for the breakout, and just a couple of very quick evaluation questions for the session. So we'll dedicate the next 20 minutes to Q&A. I know there's some really good questions here, and I want to give the audience a chance to have to listen to the speakers in answering them. So I'll start off with the first couple of questions that were around data collection. So the first question was, who's collecting the data? Is it Statistics Canada? And then the second question is related to that. Do we have any preliminary data on the impact on South Asian communities in Canada in terms of cases, deaths, and employment? Before the governments actually do this, are there any community-based led ways of highlighting this data? So before I hand it off to the speakers to address this question, I just wanted to give a bit of a update on this too. So CASSA, in our work with the Color of Poverty, Color of Change Steering Committee, we've actually been working with the Ministry of Health. We've had some conversations with the Ministry of Health, and there has been a rollout of data collection in the public health units in Ontario. They're collecting some race-based data. We are working with the Ministry of Health on how they collect that data and how it will be used by the government officials, what kind of questions they're going to be asking. So we're still in the process of having those conversations with the ministry. And we're also trying to push them to collect data retrospectively, like as of March, and not moving forward just as of June 30th, because the majority of the cases in Ontario happened March, April, May, and not, so we don't have as many cases now. So we'd like that data to be collected too. So that's my update. Anybody else have anything to add to that? No? Okay, so we'll move to the next question then. So this is a question about counseling. The question is, for the people that have lost their loved ones during this time, is there bereavement counseling? And I'll just add a little bit further. Is there bereavement counseling that's tailored to different cultures and communities and languages? So maybe I'll give that one to Aamna.
Around bereavement is the question?
Yeah.
Okay. So, so I don't, I mean, one of the things is we do have resources on bereavement. I do think though that there needs to be a cultural adaptation to that. That I know that we have at CAMH, majority of the resources are very last minute resources. So that is something that we will be looking at. But I don't have any in terms of specific to the South Asian population, but I can share the bereavement resources we do have.
I know one of my colleagues, Dr. Sohaila Pashangat-Humber, is looking at grief and grieving following loss of loved one or ones during the current pandemic. She's in the earlier part of her work around this topic, but I know she has an interest around that.
Great, thank you. So the next question is so they're trying to understand, how does health equity dismantle systemic racist organizational structures and barriers? So how can we move past looking at health equity and looking at some of the root causes of the systemic racist issues within organizations? Anyone who wants to answer that one can take that on.
So I can answer a bit because my computer is saying that it's going to restart in 4 minutes, and At a hospital, that means that everything shuts down. So I'm going to try and call in, but profoundly, it may just end when I say something that's just, I don't know. I think that one of the things is that training is not the only answer to, and I think a lot of people automatically think that one needs to get training in health equity or training of any sort to be able to look at structural dismantling. But I think there's it's a huge pronged approach of many different levels. But I think there's also, I think what we're forgetting is our own work that we need to do before we even approach training. And so one of the things that we talk about is that while training is one component of the picture around structural change, it's not the only piece. And that's been a huge part of our conversations at CAMH, is how do we move forward when people typically, when faced with any type of discomfort, go to training, right? And they think that once they're trained, the answer is they don't have to do any more work. So I think, and that's something that Baldev and I think will talk more about around supporting one another. And I think as a network to support one another on what has been, we have the Health Equity Impact Assessment Champions, and that's a huge piece of our conversation with all the health equity people around what best practices would look like that would include something beyond training. And I'm happy to share that once we have that too.
Great. Thank you so much, Aamna. So the next question is around funding. So how do we ensure that there is equity in funding during the recovery? New and smaller or South Asian organizations are appropriately supported, and any new funding does not simply reinforce existing organizations and power structures within sectors. Baldev, if you're still here, do you want to take that one on?
I think this is a very important question, because unless as South Asian organizations, we come together and we strategize how we can support each other and how we can lobby. I think one of the weaknesses for over 30 years is that we haven't been able to consistently lobby to put our need forward. And we have been kind of considered as a model community that we really don't have that big of problems. So you guys speak English, life is fine, so everything is kind of hushed over. I think all the organizations, big and small South Asian organizations, need to come together. And there are two forums. There's a CASSA. They should come under the umbrella of CASSA, and we should lobby. And then there is a South Asian Executive Directors Forum, where we meet and we take on practical steps to see what can be done based on our own limited funding, kind of a thing. So there are two opportunities that I think it's a time for us to come together and to lobby and support more, so that we can actually get our fair share.
Anybody else want to add to that? Okay. So the next question is, with the South Asian community being overrepresented in the IT sector, many South Asians that work in the tech field are benefiting from additional work income during this pandemic. How do we bridge economic class divides within the community between those benefiting and those suffering from the pandemic? Ananya, I'm going to put you on the spot and let you take that one. Oh, you're still on mute. There we go.
Hi. Yeah, that's a really great question. I mean, right now, personally, like, I'm struggling, like, how do we all collectively work together, and especially amongst us who are very structurally privileged, how are we working with the communities, again, who don't have the opportunity to benefit as many communities do? I mean, the IT sector, again, it's not an area that I'm very familiar with, but it is a complex sector. I mean, in the sense that I fully agree, there's been a lot of, there has been layoffs, but then also people who work in the IT sector have the luxury, have more the luxury of working from home. And again, that creates economic divides. Also, the IT sector has a lot of foreign workers as well, right? And that adds another layer of complexity, and it's messy, and I don't know what the answer is, but I think it really does come back. And as Baldev was saying, like, it's about lobbying, right? It's really understanding what does equity look like within the South Asian community. And I think this is a conversation like we haven't been having. I mean, if you think about South Asian, academics, health professionals, like, we're so vast, but we're also not working together as we should be, right? And I think that's something to really question as well. And it's important because we need to synergize, and I think it needs to be very collective in the sense, community organizations should not just have the onus of doing that advocacy work. And then where many of us who are academics and health professionals, I feel like we tend to be more complicit, in all honesty, especially if our work doesn't really truly center around health equity and what that looks like. And I do caution, again, the term South Asian. I think it's important to use, because we are a group in solidarity, but I think it's also time, if we're studying South Asian populations, like, we need to start digging deeper.
Great, thank you. Anybody else have anything to add to that? There's the flip side of it. It's a comment more than a question. So while South Asians are overrepresented in the IT sector, women are losing their jobs or quitting due to added household work and childcare responsibilities. Thus decrease productivity, a nuanced to take into consideration where there may be additional work and income for some. Many are losing income and having to go down a single income households. Dr. Khanlou, have you seen, or is there any data on this phenomenon where people are having to let go of employment, particularly disproportionately impacting females?
So I'm not sure if right now there is rigorous data, but someone who follows Twitter, I can see women of all sorts of professions, disciplines, places in life, talking about how caregiving of their children, as well as sometimes elderly family members during the current pandemic, has impacted their work life balance. And I think this is where that intersectionality perspective really is helpful, because the benefits are gendered, as someone said in their comments and you just read, but they're also probably very class-based. So those folks with more precarious jobs, with less rights, with less permanence in their positions, are worse off than folks who have secure jobs, are tenured, have the option of working from home. So one can apply that intersectionality perspective and assume that those who are privileged to begin with are going to fare better off than those who face more challenges, socioeconomic, social determinants challenges at the beginning of the pandemic in terms of impact on their employment. And this is nothing new for folks who do health equity work.
Thank you. Anybody else want to add anything to that?
Yeah, I could just add briefly. I think there's two ways you can look at this. One is, of course, just in Canada itself. It was on the weekend edition of the Globe and Mail. It's the front page of the business section, which talked about the fact that there can't be an economic recovery without addressing the question of childcare. And so that's where intersectionality is sort of manifested so clearly, that without childcare, it's very hard for parents to return to work. And we've seen it in Canada, and we've seen it across the world in the last 4 months. I mean, much longer, but the pandemic has sort of brought it home to light in an acute, brutal way, that when you look at the distribution of social care within households, within communities, it's disproportionately borne by women. And so you see that in this pandemic as well. The UN, the IMF, the World Bank, in the last 2-3 months have been issuing a number of reports. And who has lost work most? It has been workers in the informal sector that is highly feminized. And of course, there are other kinds of sources of stratification, so to do with that ethnicity or caste, religion, whatever it might be, in different countries, different contexts. So I think it's become really clear. In fact, I think it was the World Bank that issued a report only about a month ago that said a lot of the gains in women's employment in the labor force in the last decade in many regions of the global south have been literally wiped out by this pandemic. And what's interesting here again is that we talk about the sort of north-south disparities traditionally, but you see these sort of patterns happening even in the industrialized economies of the OECD as well. I think that's what the whole term the global south means, that what we consider as sort of obstacles to development and well-being in the South generally, in the post-colonial world, of course, are also manifested in these sort of rich northern economies, relatively speaking, that we live in, including Canada. So I think it's a really vital issue. It's very hard to understand. And I thought the headline from this week, just to go back to sort of where I began my comments, it said, I think it was one person that they quoted in this Globe and Mail story. It said, you have to choose post-pandemic. Are you going to be a parent or are you going to be a worker? You can't be both. And that's because there's an inadequacy of childcare. And if you look at countries where have dealt with this quite well, I think Denmark, for instance, would be one that you would sort of single out. That sort of forced choice is not made. And the burden is borne disproportionately not by men, by women in traditional households and non-traditional ones as well.
Thank you so much. So the last two questions, again, are on data. So or insights around South Asian communities in the healthcare profession. If there is any data on the impact of those healthcare professionals that have South Asian, that come from South Asian descent. And then the second question is around data on the impact of international students, particularly from South Asia, and the impact on those communities from the COVID crisis. So just like quickly, I think again, there is lack of data right now in Canada generally on the impact of the COVID crisis for all communities. So again, there's a push to collect that data and collect disaggregated data. And hopefully over the next couple of months, we'll start to see some of that data come out, and we'll have a better understanding of the impact of the crisis on different fields, on different professions, and on different segments of the South Asian population. So we don't have much more time. And I think that those were the last two questions, but we have quickly created the survey that I was just talking about. So it has two open-ended questions. Madiba just sent that in the chat. So if you can take a few minutes to complete the questions and then the evaluation about the event today, that would be greatly appreciated. If you don't have time right now and you have to go, that's fine. We can send an email with that survey link to everyone as well. I know a lot of folks did have to leave a little bit before 6. So that's not a problem. We can send that out to everybody. But we're hoping to feed this data in, because as an organization, CASSA does get consulted by government and research institutions and universities on the COVID crisis and the impact of it on our community. So this, your feedback will really support us in responding to that, to the recovery. There's a Toronto Office of Recovery as well that is looking for communities to provide input on how the pandemic has impacted them and how they would like to see the strategy moving forward in the recovery phase. So please take some time to do that. I wanted to thank all our speakers. I know Aamna and Banerjee had to leave, but Ananya, Dr. Khanlou, Dr. Ruparelia, for taking your time and being here with us today and sharing your incredible expertise and your research with us. And we know that this is not where our conversation will end. As an organization, the individuals that partner with CASSA on various different initiatives, we are going to continue to push decision makers and policymakers to ensure that our communities are being represented in the policies and programs and strategies that are going to be created from out of this pandemic. And we're going to ensure that the well-being of our communities is being upheld. So thank you once again, and I hope everybody has a great evening. Thank you for joining us. Take care.